I don't forget my announcements that I'm supposed to announce here. Thank you, Kylie. I appreciate that. Hmm. Okay, good morning, everyone. It is in fact 7 o'clock. So why don't we go ahead and get started because we have a lot to cover. Um, my name is Neil Davis. I'm a pediatrician at Hillcrest Pediatrics and also work on population health with our system. Really grateful to be able to have these pediatric update webinars. And welcome to everyone who's joining. Just as a reminder, cameras and microphones, as you can see on the slide, have been deactivated. Now, having said that, we really like everyone to be very active in the chat. We're going to go through some information that's really timely today related to what's going on with infectious disease, measles in particular, and then our vaccination situation, both from a where are we at and a policy kind of perspective. So with that in mind, please put your questions in the chat. We love to have that interaction. All right, Kylie is going to drop into the chat both at the beginning and at the end the CME code for everyone, so they have that. So thank you to Kylie for organizing all this and getting that code for us. Just as a reminder of the other educational CME opportunities we have, there's the Pediatric Echo series that's ongoing right now. A really great one that looks like it's today at noon from Kristen Francis about social media and youth. That's definitely a timely issue for us also. And then we just a reminder for those who interface at all with the Intermountain system, whether in clinic or in hospitals in any way, there's EPIC training upcoming in the next several months, and I believe there are ways to sign up for that. So just heads up about that. All right, next one. All right, let's get right into the topic. We are so fortunate to have Dr. Andy Pavia and Dr. Scott Williams with us today. Just as a reminder, Dr. Pavia has been with us several times. Thank you very much, Andy. He is the George and Esther Gross Presidential Professor and Chief of the Division of Pediatric Infectious Disease at the University of Utah. I was looking at this, Andy, realized that you did training in your early days at Brown and at Dartmouth and the CDC and all sorts of things. So we are so fortunate to have you with us. And then introducing Dr. Scott Williams, who was on faculty at the University of Utah for several years ago, for about 10 years, and then served in many positions at the Department of Health for the state, including 3 years as the executive director under, I believe, Mike Leavitt was governor at the time, right, Scott? So we're really fortunate to have his perspective as we get into the issues related to policy at the local level in particular. We are going to start off with Dr. Pavia. So over to you, Andy, to get us going on what is going on with measles.
Great. Well, thanks, Neil, and thanks everyone for joining. I really enjoy these sessions where we get to, I get to learn from everyone as well. For Truth in Advertising, I am no longer chief of the division. I handed the reins over to Ann Blaschke a few weeks ago. Actually, it's a few months now. Can everyone see my slides at this point?
Yes, you can see them.
Okay. So every couple of years we talk about measles because of potential threats. And this year it's unlike anything we've seen since really since the 1980s. And so it's a threat that we really should not be facing. And I think most of us are really frustrated by this. We've had a death of a child already. We're seeing many, many more kids suffering. And I want to talk a little bit about measles and give everyone a reminder about it because it's probably going to come to Utah maybe after spring break, but also because there's so much misinformation out there. And one of our jobs, and your jobs in particular as primary care providers, is to educate our patients. So here are my disclosures. They're unrelated. So just a few things about measles. It's always fun to do a little bit of history. It was probably recognized in the about 340 AD by a Chinese alchemist who described measles and smallpox separately. And measles has had a tremendous impact on history when it was brought to the Americas, first by Christopher Columbus and then by successive waves. It absolutely devastated the indigenous population, and up to 95% died. The two leading causes of death were measles and smallpox. So if we fast forward ahead to 1912, when the US started tracking measles, it killed about 26 per thousand cases in a time when we had very little health care available, when people were bled as a treatment for infectious diseases. Major breakthroughs started through the work of John Enders and Thomas Peoples. In 1954, they isolated the virus from an 11-year-old named David Edmonston, and you've seen the name Edmonston strain on the vials of vaccine you administer. 1963 was the first vaccine licensed, and it was an inactivated vaccine that had relatively low efficacy. And the first generation live virus vaccine came out there, but it was very reactogenic and really wasn't used much until the updated vaccine, which was first licensed in 68 and really hit children who were born in 69 going forward. Those dates are kind of important when we think about adults who've been adequately covered with vaccine. And then in 1989 and 91, you may remember there was a really large outbreak across the US, some several thousand cases, and a number of them were due to breakthroughs in vaccinated children. And it became clear that a second dose was more effective. Now, the other side of the history, the much darker side, is the misinformation. And it really started with Andrew Wakefield's short publication in Lancet in 1998 when he claimed that MMR vaccine was associated with the sudden onset of autism. And in 2010, a major step forward on that regard was that after careful investigation, it was discovered that Wakefield had actually falsified the results. He'd altered the histories. The Lancet officially retracted the article, something Lancet was not otherwise doing, and Wakefield lost his license. So here's a 2,000-foot view or 20,000-foot view of the history of measles in the US. In the 1960s, before the vaccine was licensed, there were about 400 to 500 deaths, mostly in children, but also in pregnant women, about 48,000 hospitalizations, and some 500,000 cases. And even with the first round of vaccines, you see this dramatic drop down to the range of a couple thousand cases per year. And then once a second dose was recommended, there was essentially the elimination of endogenous transmission, autochthonous transmission in the US, so that in 2000, measles was declared eliminated as an endogenous disease, even though it kept being imported by travelers. Unfortunately, as I think everyone knows, the situation's become much more complex. This is the epidemic curve of measles through about last week for the last several years. And you can see that after a period of very low activity in 2024, there were about 285 cases in the US in a number of clusters. None of them really spun out of control. But this year, we're seeing something very different with the outbreak in Texas. So CDC's numbers are a week old. They reported 223 cases, but 225 cases. But as of yesterday, there were at least 256 cases related to the Texas outbreak. It's now spread to Oklahoma, and new travel-related cases have been seen in about 9 other states. The age distribution is not too surprising. About a third of the cases are in kids under 5. About half are in school-age kids, 18% in adults, and then age is unknown for others. 96% of these are in people with no vaccination or no history of vaccination. All right, so measles is not confined to the US. And if you've been reading the news from Europe, you know that over the last 2 years, Europe has experienced large measles outbreaks, the worst of which in Western Europe, at least, has been in the UK, where there have been several deaths and over 10,000 cases. This is WHO figures for the entire what they call a European region, which includes Russian and the former Soviet republics. And you can see that virtually every country has experienced an uptick in measles. And it's worth going over the clinical picture of measles a little bit because I'm guessing that many of you aren't as old as me and haven't seen a lot of cases. And so, because it's so much a clinical diagnosis, it's important to just think about it for a moment. It is the most transmissible disease that we have ever studied. It has an R naught of about 12 to 16, meaning about 12 to 16 people can be infected for every individual case. And if you have an outbreak in a family, if you have a single case in a family, about 90% of the non-immune household members will end up developing measles, making it really very difficult to control without vaccine. Clinical recognition is pretty straightforward. Your grandmother and my grandmother could probably make the diagnosis of measles pretty well when it was common and everyone saw it and recognized the rash. It has a fairly long incubation period, which makes tracking difficult and makes it appear in waves. So about 8 to 10 days after exposure, the prodrome starts. That's the 3 C's that you
Andy, for some reason, you went on mute. Go, yeah, maybe unmute. I don't know why that happened. Go back to the
How's that?
Koplik spots. That's where it dropped off for us.
Okay, good. I don't know how that happened. That's Teams doing its thing. Complex spots show up in the prodrome. So this could be a child you see in the clinic who's got the 3 C's and a high fever, and a careful exam of the mouth may show these white, occasionally blue spots that look like part of a grain of rice on a red base, shown here. They're only present in some small fraction, maybe a third of kids. You can actually see them. The rash appears after 3 to 4 days. What's nice about the rash is that it is different in its progression than most of our other childhood rashes. It's pretty stereotypic. It isn't highly variable. It begins on the face, usually around the hairline or behind the ears, and progresses down the face. These days, moms are likely to have pictures they can show you of the progression that's really helpful. It will then spread to the trunk, outwards on the arms. The rash itself is pretty polymorphic. It can be macules or papules. It can be more plaque-like. It typically doesn't itch. I show you this picture here because everyone's seen this picture before. This was posted in 1963. So this person who was posed for the picture is now Medicare eligible.
It went to mute again, Andy. I don't know why.
All right.
You're back. You're
Yeah,
good.
there we go. So let's look at some pictures on kids with different skin colors, because not every case is going to be on a strawberry blonde. And you can see that the rash can become quite confluent. It can be fairly difficult to see on dark skin. When I worked in the DRC, I missed the rash on several children, and their moms had to point it out to me. So it's always helpful to ask mothers what kind of rash they're seeing. The message that we really have to get across to our policymakers, to our parents, to everyone else is that measles isn't chickenpox. It's not a mild rash illness. It's not a hand, foot, and mouth disease. Uh, no child who has measles is happy. They're miserable. They can have diarrhea. They can develop secondary bacterial infections, including otitis media. Pneumonia can occur as a direct complication of the virus. And you can also see secondary bacterial pneumonias about a week in. Diarrhea is a fairly common complication. Keratitis. Many people with measles will have photophobia, and that can be a clue. About 1 in 4 cases are hospitalized. That's about what we're running in the Texas outbreak right now. Encephalitis is one of the most feared complications. It takes 3 forms. There's an ADM-like encephalitis, there's a direct measles encephalitis, and there's a delayed giant cell measles encephalitis. Then the most scary and really awful complication is subacute sclerosing panencephalitis, which occurs about 7 to 10 years after measles and is an inexorable progressive neurologic disease resulting in death. Jim Bale and I saw one case. That's my entire lifetime experience with it. Highest risk groups are not too surprising. Kids under 5, people over 20, pregnant people, and those who are immune compromised. And the pregnancy issue is really important to remember because you'll often see a child with measles and you may want to ask about pregnancy status in the mother. Diagnosis is really important. And clinical recognition, clinical suspicion is the most important thing. I sometimes have called this the gray hair test. That is, people who've seen a bunch of measles who have got experience with it can diagnose it fairly accurately. You want to know about travel. And these days, that includes both international travel and travel to areas where there are outbreaks, exposure to somebody with known rash illness or measles, and vaccination history, because in a person with 2 doses of vaccine or prior measles, measles is going to be very unlikely. The vaccine is 97% effective. Serology is not particularly helpful in the acute phase. IgM appears a few days after the rash onset, so may not be positive at the time you first see a patient, and it also can have false positives, so it's really not a sensitive or specific approach, and you're going to have at least a 24-hour lag for that. If you get back an IgG that's positive and IgM that's negative, that's evidence of immunity. The definitive diagnosis is by PCR, and the best samples are an NP or OP swab, can also be detected in urine. Right now, as of March 12th, you have to send that through the state and it goes to the California Public Health Lab. But we're hoping that sometime in April, it will be available locally with a much shorter turnaround time through AREP. And whenever you suspect a case of measles, you got to pick up the phone first thing you do is you whisk the kid into a room, close the door, if possible, use airborne isolation if you've got it, and put on an N95 or PAPR before you see the kid, even if you're vaccinated. Then pick up the phone because you need to notify public health and infection prevention immediately. And the time course graph on the bottom is just a reminder that people are incredibly infectious from the onset of the prodrome until 4 days after the rash appears. Think about the other things it could be. Kawasaki's can be a confuser. Adenovirus infections can look fairly similar. Parvovirus generally starts on the cheeks, spares the forehead, but it's worth thinking about. And of course, drug eruptions, hand, foot, and mouth disease, and fifth disease could be in the differential diagnosis, but they have different rashes, different progressions. And Scott's going to talk more about this, but I just want to set the stage for why we are where we are. And that has to do with vaccine coverage. If you look back to 2009, 2010, this is CDC data on the coverage of children entering kindergarten. And blue indicates greater than 95% coverage. That's generally the level at which measles can't spread because of true herd immunity. Herd immunity got bandied about by people to know what they were talking about during COVID. But with measles, herd immunity is a very important and medically proven concept. But we can see is that most of the country was greater than 95%, and then a number of states were between 90 and 95%, but relatively few states were below 90. But if you contrast it to 2023, 24, the latest time we have data for, you can see a large number of states are below 90, which makes them highly vulnerable to measles spreads. And that includes Colorado, Utah, Arizona. And only a small number of states are maintaining greater than 95% coverage. And just to look at where we were just before the pandemic, you can see we'd already seen erosion compared to what was previously on the left-hand part of this slide, with many fewer states remaining in the blue or safe range. I'm going to let Scott go over the local data because I think that's really important, but we have pockets of very low vaccination within Utah. But I did want to mention a few things pulled from the news that really are influencing this. So There has been a lot of restrictions on our federal partners in their role in trying to control this. The ACIP meeting in February was canceled. It's not been rescheduled yet. ACIP is incredibly important to us for our vaccination guidance and reviewing vaccination safety. The NIH was announced yesterday was forced to cancel 33 studies that focused on vaccine hesitancy and strategies to improve vaccine uptake. There was a feature article in one of the newspapers from Texas about how much the public health infrastructure in Texas had crumbled in the last 10 years and how many struggles they were having in just tracking and counting the measles cases, let alone implementing control measures. CDC has not really been able to take as prominent a role in giving guidance and warning people, and that's another sort of fallout from the current status we're in. CDC also had to diverse resources into an unnecessary repeat study on MMR and autism. That will be the 28th study. The first 27 showed no association. Guess what this one will show? And then there's been a lot of misinformation out there that's being spread from parent to parent, group to group. I will have to be a little bit political because RFK Jr. has been making some really dangerous statements. He's advocated treating cases of measles with cod liver oil, budesonide, and clarithromycin. So think about it. Vitamin A replacement doesn't hurt. Budesonide is a potent steroid, and one of the big problems with measles is it depletes your memory T and B cells. Adding a steroid to that is almost certainly harmful to your immune function going down the line. There's no benefit that it helps. And clarithromycin is a relatively poorly tolerated antibiotic. Using it to treat a virus is not only unnecessary antibiotic treatment, but pretty much guaranteed to cause abdominal pain in a number of kids, as well as have potential drug-drug interactions. So I'm going to stop there. We can talk about vaccination a little bit and ways that we can accelerate vaccination in the face of a measles outbreak. But I think in the interest of time, I'll skip that right now. And
And
thanks, and I will turn it over.
yeah, Andy, let's cover a couple questions that have come through in the chat here. So from Gary Bosshart, we've got a comment. I know vaccination against measles while pregnant is contraindicated. However, have there been any actual cases of live virus vaccine that was transmitted to the fetus in cases of accidental vaccination during pregnancy?
It's a great question. I'm not aware of any cases that have actually been documented. Measles in a pregnant woman is largely dangerous to the pregnant woman, but is associated with premature birth and stillbirth. So it would probably be an issue of a danger of premature birth if you vaccinated a pregnant woman. And obviously, there's some risk of teratogenicity. So pregnant women who are exposed to measles who don't have immunity need to get IVIG or intramuscular immunoglobulin as their form of prophylaxis. So one thing to think about is to review the vaccination status of women who are contemplating pregnancy, which may be the moms of a lot of our patients.
Thank you. Great question and great information about that for the moms that we're interfacing with as well. Thanks, Andy. Question from Tim Duffy. Do we have a sense of what vaccine modified presentation would look like? i.e., if they have one dose, are they still typically febrile? Does the rash appear different?
Yeah, there's not a really distinct syndrome of vaccine modified measles. Generally, if it breaks through, it follows a typical course, but the overall illness may be milder. So the chance of complications, including hospitalization, are lower. But as far as I know, and I could be wrong on this, the rash is still typically centripetal, starting in the forehead and descending, but it may be less prominent and the person may be less dramatically ill.
Great. Thanks, Andy. I've got a quick question for both you and Scott. So, putting on my, community pediatrician hat here, I'm going to go to clinic. You mentioned we've got to have our PAPRs ready, our N95s ready. Um, Probably would be a good time for us to review with our staff. Like, because it's not just us, our staff is getting phone calls, our medical assistants are rooming people. I mean, what would you suggest we do with our team um, right now to just help people be aware?
Yeah, great question. Scott, do you want, I can take that, or you can?
You go ahead, Andy.
Okay. So one thing, and we're doing this on our interviews and social media, is to ask people who think they may have measles to call ahead. And if they do, then what you can do if they is take a history over the phone. If they sound very sick, send them to the ED with a warning to the ED that they might have measles because EDs have negative pressure rooms. If you're not sure and you want to see them, the thing to do is to warn the staff just to bring the child back to a room and close the door right away and to wear an N95. Um, Putting a mask on the patient will probably reduce spread because source control from coughing is probably very helpful. Um, and I think the other thing that could be helpful is just to show some pictures of measles rashes to your front of office staff so that, any child with a facial rash gets whisked back to a room.
I guess the only thing I'd add to that, Neil, is that people identify what the measles vaccine status is of their staff and also of the staff in the pediatric units in their hospitals.
That's a great point. Intermountain, a number of years ago required proof of immunity, as did the university, from every employee and new hire. But that's not true of every healthcare facility.
Yeah, great point about make sure we're asking about measles vaccine status, Scott. We're getting a little echo again. It seemed to get better. You made a little change at the very beginning and it got better and seems like the echo's back a little bit. Um, just a heads up about that as we get ready for your slides. We've got a couple questions to cover quickly here too from Rajiv Kadu. Should we all get screened for measles IgG antibody?
So if you've had two vaccines or if you've had measles, no. And that's pretty clear recommendation because you can actually lose IgG and still be protected if you've had two vaccines. If you were born between 1959 and 1989, and you don't know that you had two vaccines, then it may be reasonable as a healthcare practitioner to either just go ahead and get a second vaccine or to get your IgG checked. If you know that you received a second dose of vaccine, say for medical school or residency, you're covered.
Great. And then a similar question from Dr. Brooke Drollinger, getting lots of work. She's a family medicine physician, getting lots of worried questions from adults about revaccination. So you mentioned some
Yeah.
guidelines already. Anything else to add to that?
So yeah, CDC says during those for people in those age groups who've only had one vaccine or may have had one vaccine, if you're traveling internationally or to Texas, you should get a second dose. I think you should offer that second dose to anyone who's had one dose of vaccine, because you never know when we're going to become one of those outbreak destinations. And certainly, if you're in healthcare, absolutely, you need the protection.
Okay, let's go to Susan Cochella's question here. I have heard talk of shortages of MMR vaccines, and she takes care of adults too, as a family medicine doctor. Can you update us on shortages and recommend how to prioritize?
So we, in our discussion with the health department on Monday, they thought that McKesson was delivering it without any problems, but the on hand stock was running short, so people were having to reorder. There certainly is the possibility that we're going to run into a shortage as the outbreak progresses. Um, and I think we haven't really talked about or thought about a prioritization scheme, but I think first doses should always be prioritized over second doses because you get 93% protection. So rather than revaccinating adults who've had one dose, make sure that kids are getting their first dose and second dose, I guess would be the strategy um, to think about. And then, of course, those most likely to be exposed should be prioritized for vaccine.
Okay. And I feel like that's something we can collectively as a system let people know about. So right now you're
Yeah.
hearing that it's more local people are using their supply rather than like McKesson, the big delivery
Yeah.
system.
I'm going to reach out to Aaron Fox, and many of you know that Aaron is kind of the guru of national drug shortages, and see what she knows, and I'll send you that information, Neil, and you can post it.
Great. Excellent. Thank you. And then a great question here from Angela De La O. I hope I'm saying these names correctly. Please, I apologize if I'm not, but please just okay, we haven't covered
Yep,
this yet, so you're good. Should we start vaccinating all kids at 4 weeks after their first dose? Similarly, should we start vaccinating 6-month-olds?
great question, Angela. I think that well, as you know, you can give a dose for anyone between 6 and 12 months if they're traveling to an endemic area or if they're just very worried, but that dose doesn't count. And the second dose can be given as soon as 28 days after the first dose. What we know about most vaccines is that priming and boosts works better if there's a somewhat larger gap. There's affinity maturation of B cells that goes on. There's T cell memory that is being formed. So 28 days is certainly okay. If there is no measles in Utah and somebody's not traveling, I might try and wait 2 to 6 months if I could. But I think that it's a good idea to get kids their second dose, in their second year of life right now without waiting for kindergarten. We do it in kindergarten because of school entry requirements and because that's when they come to see you, not because that's immunologically a better time.
Wow, super helpful. Great question. Um, let's see, that kind of goes along with Steve Lee's question. When would routine MMR vaccination for those 6 to 12 months of age in Utah be warranted?
I'm sorry, I was reading this update, which everyone should read about the vaccine supply that was in the chat. So could you repeat the question?
Yeah, sure. And thank you, Brooke, for dropping that in there. Appreciate that. Steve Lee said, when would routine MMR vaccination for those 6 to 12 months of age in Utah be warranted?
Um, the most important use of it would be for a child who'd been exposed. So when there was an outbreak in their sibling school, that's when you would absolutely want to do it proactively and do it within 3 days of the exposure. I think that if we had an outbreak that was spreading out of control and you had kids who were in congregate settings like daycare, that is absolutely an indication. I think we've always been pretty good at containing our outbreaks to under a dozen cases, and hopefully that's what would happen here in Utah. Um, I'm not sure I would rush to do it if, when we have our first case, unless parents were really worried or they were in daycare. But I think that's a discussion we should probably have in more detail with public health.
Okay, great. Um, let's see, there was one more. What about vaccination of older adults with unknown vaccination status? I think you said probably good for them to get it, right?
Yeah. If you've got unknown vaccination status, then if you think I think getting it is usually the safer choice.
Okay.
There's not much downside. Adults may get some arthralgia 7 to 14 days out. They may get a mild rash 7 to 14 days out. You get a little bit of a injection site pain and fever, but it's a relatively well tolerated vaccine, and I'd err on the side of doing it. I got an extra one just to be an example, not because I needed it. And
Okay, great. Is it an alternative to get the IgG titers for those people, or is it just better to get the second dose?
It's an alternative.
Okay.
If the titer is strongly positive, that's indicative of immunity. If it's low or below the threshold, we don't know what that means for sure because the commercial test isn't super sensitive. So if someone would rather get the test than get a dose of vaccine, go that way.
Okay, let's take two more questions, and then I want to get to Scott's slides kind of about our local numbers, and a little bit more discussion about policy here as well. So Alexander Barrera says, should we use Pro-Quad for early boosting, risking more febrile seizures? I'm assuming in
Oh,
1-year-olds as opposed to just 4-year-olds there.
yeah. I don't know the answer to that. Um, I think if the alternative is to, of course, give single dose varicella vaccine instead after you've given the MMR for the second dose early. I'd probably do that just because this is not, people are so concerned about vaccine side effects in the current environment that it's probably better for encouraging vaccine confidence. But I don't know. Great question.
Great. And then one more here. If a family from Dr. De La O again, if a family is flying, not internationally, with a child that's not completely immunized, should we immunize them?
Well, I certainly would if they're over 12 months, I would. And that's absolutely the kid who should get it 20 days, 8 days later, because, there've been cases in airports of people returning from overseas. Just today, a new case in New York State, and the second one was in Maryland at Dulles Airport. And I think 9 to 12 months, I would probably do it. 6 to 9, there's some concern about blunting future response. So it becomes a more difficult decision.
Great, thank you. And then Dr. Rena Tam has put an article uh, in the chat, which looks excellent. Thank you, Rena, for this. She says just validating Dr. Pavia's response. This article describes possible blunting of subsequent MMR response if given under 9 months and reserved for outbreak or high-risk patients. So thank you for putting that in. And
Thanks.
okay, Scott, first, any comments on this piece about the vaccine? I'll go on. And then second, if you can go to your slides.
I just wanted to ask Andy one more question. There's a lot of talk about how having measles makes you more vulnerable to future infectious diseases and increases your morbidity, and that it's responsible for far more deaths than just the measles cases themselves. Do you want to talk about that?
Sure, that's a really important feature and probably contributes to why measles is such a killer for malnourished kids and kids around the world. So there's a really substantial depletion of memory T and B cells that follows measles infection, and it's been called immune amnesia. And there's a lot of data showing that deaths from diarrhea, deaths from pneumonia increase in the 6 months to year following measles in developing countries. We don't have similar data in the US, but that immune amnesia effect almost certainly is true. And so kids may be more vulnerable to getting pneumococcal disease or group A strep or something afterwards. Hopefully in the US, we won't see the kind of spike in deaths that you do in Africa, but it's another important reason not to get measles and not to have measles parties, and not to say that natural infection is better than vaccine.
Excellent. All right, Scott, there's still a little echo, but as you talk, it seems to reduce a little. So let's just go for it. You've got great information and we want to hear from that. So over to you to cover some of the info on the local environment. And also, to mention a little bit about the document that the team has been working on as well.
Right. Well, so hopefully this echo will diminish over time. I don't know what's happening, but if it gets too bad, we'll have to figure out what to do, Neil. My only disclosure is that I had measles when I was a kid, and I'm now Medicare eligible. So I do remember that experience. Are my slides up, Neil?
You can share them, Scott, or Kylie can share them. Up to you.
Oh, I sent them to Kylie. I thought that's the
She
way
can share
it
them.
worked.
Yep.
If she can pull them up.
Yep. There you go.
Okay.
Hey, Scott, there's a good suggestion from a good suggestion from Dr. Duffy, maybe to turn your volume down on your computer a little bit and see if that helps.
Yeah, let me do that.
Okay, and let's just go for it. We want to hear your information. So.
Okay, I'm going to turn my volume down right now. Is that better? Okay, good. So this is just the introduction. You can go to the next slide, Kylie, and I don't have that many. So this is what Andy was talking about. And the introduction to this is Neil and I were asked to work on a work group to try to address the issue of the policies that are interfering with measles vaccine compliance. So far, we still have a kindergarten entry requirement, but there are advocates in different sectors that are trying to get states to get rid of the mandates for kindergarten entry vaccine requirements. And I'll talk about those in a minute. So we've been working on a kind of a white paper to present to policymakers. And the incentive for this is this slide right here. So as Andy said, since about the before the pandemic, 2015 or so, the measles or the kindergarten entry vaccine, which measles is part of, rates have declined, and they're now down from a high of all vaccines in 2015 of around 91% for all vaccines, down to now we're down about 87%. And as Andy said, with measles having an R naught of between 12 and 15, it means that there's kids across the state that are highly likely to get measles if we were to have this kind of epidemic that has occurred in Texas. And I understand there's now a case in Vermont that was just reported. Next slide. So I just wanted to show you, and Andy had this slide up for just a minute, but so we have 13 local health departments in the state, and some of them are multi-county health departments and some are single county health departments. And this is the range of kindergarten entry requirements for or compliance for individual vaccines across those local health departments. So you can see at the top being the worst, is the Southwest Health Department, which is comprised of Washington County, Iron County, and Kane counties. So St. George, Cedar City, Kanab, some of those communities. But they also have the community of Hilldale, which is a fundamentalist community where there's a lot of vaccine resistance. And I'm going to show you in a minute a slide of the individual schools in that district, because some schools are doing quite well and some schools are doing poorly. So just seeing this one statistic doesn't really help you know whether individual kids at an individual school are particularly susceptible. And then you go all the way down to Salt Lake, San Juan County, and Tooele County, where the rates of non-compliance are lower. But again, even in those counties where it appears that the health department is doing quite well, there's individual schools that have much lower vaccine compliance rates. So next slide. So this shows you, and on the Utah Department of Health vaccine information webpage, you can actually look at the data and see individual school immunization rates by city. They don't have it by school district, which I need to talk to them a little bit about because I think that would be more helpful. But you look down on the first table, there is St. George, and you can see that the Bloomington Hills Elementary School is at 85%. The Coral Cliffs School is at 100%, but the Bloomington Elementary School is at 67%. So even within that one local health district, there's a fair amount of variability in how much compliance there is with kindergarten entry requirements. And most of these kids would have signed an exemption form, and we'll talk about that, or their parents would have signed an exemption form, and you're all familiar with those, but we'll talk about those in a minute. And then over on the second table, in the Salt Lake County Health Department, in the city of Salt Lake, there's vaccine rates for individual schools that range from anywhere in the 70s, where Backman and Franklin School and Mountain View, all the way up to 100% at the Catholic Cosgrove School. So again, it's good to know what elementary school not only your patients are in, but their siblings are in. And then you can go in and see what the immunization compliance rates are in those schools. And it also helps if you're advocating for vaccine compliance in your community to know a little bit more about where the holes are that need to be addressed. Next slide. So this is a slide that describes what we've been dealing with. Back in June, a vaccine injury compensation attorney named Aaron Siri, who is kind of leading the vaccine reform, if you will, movement. He's been presenting to state legislatures all over the country, and he has the largest vaccine injury compensation litigation practice in the United States. He presented for an hour to the Utah Department of Health and talked to them about the problems with vaccines and why we should get rid of school entry requirements and why vaccine manufacturers should be made liable for vaccine injury. And let me just back up a little bit. So back in the 70s, after the swine flu vaccine situation happened, the vaccine manufacturers started dropping out of vaccine manufacturing due to liability problems. They were getting sued. And it wasn't just for, legitimate injuries. It was anybody who had anything happen to them after they got a vaccine was starting to sue, and they were dropping out of the manufacturing. And so in 1986, Congress passed the Vaccine Injury Compensation Act, and that provided a mechanism for people to make a claim, and that claim would go to a panel at the Department of Health and Human Services that would look at the data from the literature about whether the injury that was claimed was known to be an associated injury with that vaccine, and then would make a determination. And that determination can come in one of four ways. The HHS can either say, yes, your injury based on the literature is likely to have been related to the vaccine, or they can say, they can deny it, and then it can go to a special master who will say, based on our best ability to assess what happened in this situation, we're going to provide you with compensation, even though we can't prove it was associated. And then the third way is that without HHS admitting any causation, they can settle with the family for compensation, or it can be denied, at which point the family can appeal that to federal court, and then it can work its way up the federal system all the way to the Supreme Court. So that's the way liability now works for childhood vaccines. There's a very separate process that's somewhat similar for COVID, but COVID isn't part of this, but it covers children and it also covers pregnant women. So when Aaron Siri says that vaccine manufacturers have no liability, that isn't true. It's just a no-fault process that is used to try to manage the liability so that vaccine manufacturers won't quit making vaccines. One of the final slides in Aaron Siri's presentation was this quote that says PowerPoint slides, and there's the link there. That mandates are the tools of bullies, criminals, and dictators. If a patient refuses a medical product after being conveyed its benefits and risks, that is called informed consent. They were informed and did not consent. Mandating over this objection is immoral and illiberal. Well, we have a way of people who object have the ability to get exempt. So they're not being required to have a vaccine against their consent. So this is a highly misleading statement. But Siri uses it to kind of frighten state legislatures into the fact that people's personal freedom is being taken away. And so he promotes three particular pieces of model legislation. One is called the Minimum Standards Bill, or the Vaccine Confidence Bill. And when asked at the legislative hearing in the Utah legislature if any current childhood vaccines would meet the minimum standards established in this bill, he said no. So there's no childhood vaccine that would meet the standards that he's promoting. And then the next one is that if there's no liability, there's no mandate. So he connects restoring limited vaccine manufacturer liability with that's the only way that mandates would be acceptable. And in essence, he's trying to get rid of mandates with that bill. And then the other one is a medical exemption standard bill, and that is that any medical provider who says that a child should be exempt, regardless of whether there's any justification for that statement, that has to be accepted as a medical exemption by the school system. So one of our state legislators, Representative Ken Ivory, has suggested, he asked the committee if they would support him introducing these bills into the legislature this year, and they asked for more information, and that wasn't done. But it's pretty clear that Representative Ivory has an interest in introducing these bills in future legislative sessions. There's a local organization that is aligned with Aaron Siri called Your Health Freedom, and the founder of that is a woman named Kristen Chevrier, and she is now a state legislator from Alpine, Utah. So we expect to see legislation coming from her, anti-vaccine legislation as well. Next slide. So there were two bills that were introduced in this session. Neither one of them is particularly worrisome. One is a bill that has been, it's a model bill that's been introduced all over the country that designates any food that intentionally contains a vaccine or a vaccine material needs to be designated as a drug. There is some research trying to find different ways to make vaccines easier for people to get and to accept, you know, the multiple shot problem. But there's no vaccines right now that are currently even close to being approved with a delivery vehicle of food. And so this was sort of a preemptive bill. So it kind of may affect some future research, but we're not that worried about it. The second one was, in the past, when someone has an exemption form in a school and they change school, they had to fill out a new exemption form. This bill just required the previous school to transfer the exemption form to the new school, which that's a reasonable thing, and we're not too worried about that. But it shows that there are legislators that are starting to chip away at the current vaccine policy in the state.
Could we make sure that those who
are...
are...
to give you the website in case you didn't have it, of where the Utah vaccine exemption rule is and the education materials. Currently in Utah, if you want an exemption, you have to go through a video module and answer questions in order to have the your exemption form be valid. And there's this Your Health Freedom group is trying to remove that requirement of having to do the educational module on the vaccines. Next slide. Is there another slide? Oh no, that's the last slide. So I think it's important for pediatricians. There aren't that many voices right now that are pushing back on this in the state. So it'd be fun in the discussion to find out what different pediatricians believe they can do in their community or at the state level to help get this message out, because the misinformation is really eroding our ability to have vaccine compliance levels that are protective.
Scott, thank you for that great information. And then a couple things just to add to that. Kylie, I sent you an email with a document that this white paper that is being put together by the group formed with Voices for Utah Children and United Way. And that group is open to getting feedback from the providers here. So if you don't mind dropping that document in the chat, people can take a look at that. I feel like it's a good document. It gives a fairly concise summary of the history of vaccines, why they're important, what our situation is now. And so I think that group would love that information, and you may find it useful. That document should be formalized within the next few weeks to month, and then we can send that back out to everybody to be used. Question for Andy and Scott. Really good question from Dr. Stacy Townsend. do we have your permission to share these slides on social media? So the slides we've been using today, is it possible for us to send that out to the group and for this group to use this within their circles to educate people?
I'm okay with that.
Andy,
You're
you're
on
you're
mute.
on mute.
I would probably take out slide 17, which discusses sort of the political background, because I think, for some people that may be too political. I don't think it is among pediatricians.
Okay, so I think we can, if we send the slides out, please be thoughtful with how we use that, understanding that the evidence on this, as far as I understand, the most effective thing to work with people on views of vaccines is respect. Actually, showing that we respect people, their views, we listen, we can share information, but we want to show professionalism and respect. I think, and sincerely listening to people. Listening and respect, this is a summary of the evidence, seems to have a bigger impact than trying to prove a point. So as we're thoughtful with how we deliver this information, I think that's important too. Any comments on that, Andy or Scott?
Well, the other slide, Andy reminded me, the Aaron series slide, I'd be really careful putting that information out on social media, because what's likely to happen is the Aaron series supporters are likely to get into kind of a smackdown around his claims. So again, with the idea that we're trying to educate people with respect, we don't want to get into that kind of a debate on social media.
Yeah, I agree. I mean, I think among us, talking about the personalities involved is helpful, just so we know who the opposition is. But, it's anything ad hominem is going to just degrade the debate and make it more difficult to talk about what really matters, which is keeping kids safe.
Okay, excellent. So thank you, Kylie, for that. It looks like we can't put that document in the chat. We will send that out to everyone so people can look at that, give feedback on it, and then we'll send a finalized copy out. I actually used this document with a parent who was asking in good faith questions in clinic a couple weeks ago about vaccines. Like, it was a good discussion. And I shared this information. It was very helpful for this particular parent. So we can send that out. We can send the slides, be mindful, I suppose, of how we use them. Let's see. Another great question here from Susan Coachella. If parents are open to looking at the school-specific data, can we direct them to a website with this data? Scott, is that information all on the Department of Health website?
Yeah, let me pull up that website and I'll try to put that link in the chat.
Okay, that would be great. And then Miguel Canocal, Dr. Miguel Canocho, I'm always confused on how to say your last name, Miguel. I'll get it right someday. Just question on Franklin School. We're going to want to look at our data and make sure that we are providing access, because there may be some access issues as well. Any thoughts on that for Franklin School?
Oh, it's just one of the schools with lower socioeconomic status and mostly languages other than English spoken there. So I thought when I saw Franklin School low, I thought that is probably more likely to be a access issue than like a vaccine hesitancy issue.
Thanks, Miguel. That's a great comment, and that's something we should take note of and follow up on. So I really appreciate that.
And I'm not sure that, I haven't checked to see whether or not all our educational materials and UDHHS is available in Spanish and other languages. I assume that it is, but we should be aware. And I'm always aware that, I get requests from Spanish language media, but my Spanish is extraordinarily rudimentary. So, Miguel, we need a good native Spanish speaking advocate to do some of these interviews, as well as maybe be a social media influencer.
And that gets to Lonnie Miner's question here, and we can take this as our last question. He says, as a neonatologist, we're running into this problem with vaccines, vitamin K, antibiotics. It's becoming very difficult with new young families, especially. Many say they've done extensive research, and many are frustrated that we present only our side. Most don't know about the history of diseases we are fighting against. How do we become influencers on social media? Um, so again, that document that we're preparing could be helpful here. Lonnie will send that out. Comments from Scott and Andy as we wrap up. Last question.
Well, asking Scott and I how to become social media influencers is probably missing by about 3 decades. But I think it's a great point. Social media and the use of influencers is really the way people are getting educated these days. And we need good, charismatic voices for rational medical care that are doing it. There are a few out there, but not enough.
Scott, anything else? Yeah.
I think pediatricians have a more powerful platform than social media, and that's their offices. And I think that one of the things I was thinking is that if there was a picture, one of the pictures of kids with measles, because one of the problems parents have with the Aaron Siri theory is that if there's a demand for this product, people will go seek it. But there's no demand for it because the parents have never ever seen a kid with measles. It's not top of mind for them, right? So if there's a picture of what a kid with measles actually looks like, and then a list of what the measles immunization rates in the schools in your town are, and you can have that conversation about if your kid was at church with a kid who goes to this school or on a soccer team with a kid who goes to this school, they would be likely to get measles, and this is what could happen to them. I just think we need to go back to educating people in our practices about what these diseases are and what the risks are. And I think that's a more powerful way of communicating than trying to post on social media myself.
And stories are always helpful. If you've seen a child with measles, if you've seen a child die of measles, as I have, that's really powerful. The other thing is, in an era where people saw these diseases all the time, it's worth saying, in the 1960s, moms stood in line with their child in New York City in the cold, waiting for a chance to get the polio vaccine because everyone knew what it was like. And the same was true for measles. And the reason you don't know what these diseases look like, so you don't have that same sense of urgency.
Okay, let's wrap up. Thank you very much, Scott and Andy. Really appreciate it. The CME code for those listening is 40384. Again, 40.